Okay, the last two presentations on case 1 were a lot longer than I wanted them to be, and I'm not going to have time to cover in this video a few things that I wanted to cover. The main thing being heart failure. So heart failure, I think I'm going to go ahead and try to do a presentation on that sometime either tonight or tomorrow. But for now, we'll go ahead and do post-cardiac injury syndrome, and especially it's a pericarditis, so I'll talk a little bit about pericarditis. So again, with the anatomy, we've got the pericardium right here, and the pericardium actually has a function. It actually attaches. You can see it attaching right here to the diaphragm. It attaches a couple other places as well. For example, you can't see it on this image, but it actually attaches to the sternum as well. So the fibrous parietal pericardium right here, it's usually about 2 millimeters thick, and it's mostly acellular, made up of collagen and stuff. But the visceral pericardium is a monolayer of mesothelial cells and collagen. So even though this is 2 millimeters thick, the visceral layer is a monolayer of mesothelial cells and collagen. And normally within this sac we have less than or equal to 50 milliliters of fluid. So it functions in restraining the heart, keeping it in an anatomical location. So it keeps the heart in a specific location. It provides a barrier for infection. So infection, it has a lot of, what I'm pointing out is it has a lot of functions. It has both mechano and chemo receptors. So I'll just put receptors. And the phrenic nerve travels through it. And the phrenic nerve will actually participate in carrying pain signals and also in various neurological reflexes. So a reflex up the phrenic nerve and back down the vagus nerve, for example. Now, one of the most interesting things is the elastic nature. So I'll try to describe this. It's like a rubber band. So you have a rubber band, and you can stretch that rubber band out pretty easily. But once it gets to a terminal position, you can't really stretch it anymore. It's at its maximum, and so the pericardium kind of has that same property as well. Now, pathophysiologically, let's imagine that the heart is right here, and let's imagine that we have all of this space filled with a fluid, like an effusion. So there's a pericarditis, and we've got an effusion in here, and it's filled up. And so once you get to that maximum effusion, like just adding a little bit more volume to that will cause the cardiac output to reduce significantly. So you can get up to that maximum fluid, no really big deal. But once you pass that maximum, the cardiac output goes down significantly with a little volume. But also, whenever you take in a needle and you withdraw even just a little fluid, even just a little, cardiac output improves significantly. So just a little change when you get to that maximum point can either improve or cause pathology in cardiac output. So all that is said because you can actually remove the pericardium. It can be removed with no obvious consequences, but it still has a function. So functions in restraining or holding everything in its anatomical position. It's got a pressure-volume relationship like I just described, and then there's a pericardial effusion will initially be compliant, like I was just showing. Then it will hit a wall and it will be non-compliant. And this, of course, is just a partial list. I basically gave you a more exhaustive list in the previous slide. So pericarditis, let's talk about that really quick. Most commonly it's termed idiopathic, and when it's termed idiopathic, typically that means viral, but viral assays aren't typically done because it really doesn't change the management if you find out that it's viral. Now you can have two types of pericarditis with MIs. You can have an early myocardial infarction pericarditis, and this is usually like if you get a transmural infarction. So let's say that this is the myocardium, the endocardium, and the epicardium. So let's put some blood inside of here, and we've got 3 layers of tissue, and then on the outside of that we have this pleura, and of course we have the visceral layer as well. If you get an infarction all the way through a transmural infarction, you get necrosis and you get macrophages. So macrophages will want to come in and eat up all this stuff, and they can actually cause breakage through the wall, and so you can actually have blood coming through, or you can just have a crap ton of macrophages come in here as well and cause inflammation. And typically I'm saying macrophages. This can be neutrophils or macrophages doing this, so I'll put in some neutrophils as well, some green neutrophils. So when this happens, it's usually going to happen 1 to 3 days, 1 to 3 days after an MI. And if you watched the Pathology video on myocardial infarction, you realize that there's a 1 day, 1 week, and a 1 month episode whenever you're talking about MIs. And so up to the first day you don't get any inflammation, but then after the first day you get neutrophils for the first 3 days, and you get macrophages from day 4 through 7. So that first week you get these inflammatory lymphocytes. I'm sorry, not lymphocytes, leukocytes. And so it's important to distinguish these two because the prognosis changes. So the prognosis, if you don't catch this early MI, pericarditis, then it's typically going to be more deadlier than if you are, you miss this diagnosis. So the late MI pericarditis, this is called Dressler's, and it usually occurs weeks to months after, and this is probably going to be autoimmune in nature. And so this is one of the post-cardiac injury syndromes that we're going to talk about in a minute. Now there's over 50 causes, so I didn't count all of them. Once I got to like 45, I quit counting, but in the textbook, it was on Clinical Keys, Diseases of the Heart, there were 50 causes listed, more than 50 actually, of pericarditis, but they can all be broken down into these categories. So they can be idiopathic, which we said most times if it's idiopathic it's viral, and then there's about 10% of the idiopathic that probably can't be attributed to viral, probably a bad workup, I'm guessing. This is a misspelling of infectious, so the idiopathic infectious would include the idiopathics that are really viral. Coxsackie virus, for example, HIV causes pericarditis. You can have inflammatory. This is going to include your autoimmune most of the time. This is going to be the rest of the autoimmune, which is going to be trauma and surgery. Autoimmunes are going to be in that category, but you can also just have a huge blow to the chest that just destroys not destroys, but it really hurts and injures the pericardium. Early and late MI, cancer, and radiation. And a lot of these things are going to overlap with the post-cardiac injury syndrome. For example, radiation can cause post-cardiac injury syndrome. So according to the heart textbook on Clinical Keys, the almost always going to have chest pain, but I'm guessing because either our patient was on codeine or because our case was written up so that we wouldn't figure it out like immediately. She didn't present with chest pain. She presented with a whole bunch of symptoms that would suggest maybe a pulmonary embolus or something. But chest pain, almost always, not always, but almost always, and it's relieved when leaning forward, made worse when laying back. It's usually substernal, but can be epigastric or in the left anterior chest wall. So just think of substernal chest pain, better when you're leaning forward. Some other signs and symptoms, they're not super specific or sensitive, but dyspnea, cough, and hiccups. Our case study, our patient did have dyspnea. And then the other thing is going to be check your past medical history. If there's a history of viruses, surgery, cancer, or autoimmune, then, and especially if it was recent and you have other clinical suspicions for pericarditis, then you should check it out. Some other symptoms would be fever, chills, rash, and weight loss. So these are all kind of non-specific, almost like cancerous type of non-specific stuff. Or you might think like tuberculosis or, those crazy things that always cause fever, chills, rash, and weight loss and that kind of thing. So whenever you have a suspicion, you typically want to rule out a few prominent things. So pleurisy, pulmonary embolus, costochondritis, GERD can be confused with pericarditis. Pneumothorax is pretty big, and then herpes zoster can cause pain before lesions appear, and it can be in that area, that substernal pain or the epigastric pain. Physical exam, you're going to get a friction rub, so you're going to have your patient lean forward. So the patient's going to be feeling better because they're going to be leaning forward, but you're going to have them lean forward because you're going to hear the friction rub better. And it's not always heard, but when it is heard, it's pathognomic. So you hear that friction rub when they're leaning forward. you know that's pericarditis. And so the textbook recommends listening frequently because it can come and it can go. So go and listen, auscultate all the time. Just go and check on your patient and auscultate. And it's going to sound like walking on crunchy snow. So it's at the left lower sternal border while leaning forward, and auscultate frequently. So, and then on the EKG, you're going to see an ST elevation in a lot of leads. So in all of the leads, usually except for AVR and V1, and it's different from MI. The reason it's different from MI is because with a myocardial infarction, you see the ST elevation in the leads near where the injury is. So less leads. I'll just put that. So like you can look at where the ST elevation is, what leads it's in, and you can almost zero in on where your which part of the heart your myocardial infarction is at. The other thing that makes it a little bit different is typically you're going to see PR segment depression. So let's take a look at it. Here is the EKG or ECG. We've all heard it both ways. So I'll just zoom in here on lead 1, and you'll see that there's this PR segment depression, like the PR segment is going down, and you also see the ST elevation. But let's take a look at all of these leads. So I'm going to see, of course, it's upside down here, but this is ST segment elevation. You can turn it over and see it, ST segment elevation. You see V1, I'm not seeing it. Or really, it's rather mild if it's there. And then, let's see, AVL, I see some elevation. Lead 2, lead 3, I think this would be T-wave inversion, but you can correct me if I'm wrong. I see some ST elevation there as well. So you see the S segment is elevated, and it looks like maybe T-wave inversion with it. AVF, you've got elevation again. Down here, the rhythm strip, lead 2. V3, you've got elevation again. Then coming on over here, we see in V6, V5, V4. So we see a lot of, like it's everywhere. So like either the whole heart is infarcted or else you have a pericardial pericarditis. And again, the PR segment depression. So typically, depending, you can get an effusion. So with pericarditis, you can get fibrosis. You can get different kinds of pericarditis, whether it's acute or chronic. Typically in the acute phase, you're going to see an effusion, and you can see pericardial effusion and or pleural effusion. Now, I don't really have time to cover all of the different types of pericarditis. You should be aware that there are differences in constrictive. So you got constrictive, this is probably something good to go look up, and restrictive, the differences between these two. So you got constrictive pericarditis and restrictive pericarditis, and the textbook I was reading out of made a big deal out of knowing the difference between these two. So here's your pleural effusion again. We've seen this in the case. You can see on the patient's right side, the costophrenic angle is nicely seen. Over here, it's not, and so that indicates an effusion. And the way you can really check that is you can have the patient lie down. And so these are, of course, aren't the same pictures, because in this first picture, there's nothing on the right side, but on the left side there is. So clearly, I'm using different X-rays and stuff. But whenever the patient lays down, you'll see the fluid move from the costophrenic angle into a different area, and so as you're seeing right here. And I couldn't find a really great lateral x-ray, but in the lateral x-ray you can look at it as well. This is of course computer generated because nothing looks this pristine on x-ray, but you see that you get some blunting of the angles back here as well. So post-cardiac injury syndrome, this is basically a pericarditis, and the etiology is believed to be autoimmune, but there's some debate. So we'll talk about it. So what's the evidence for autoimmune? It's usually seen weeks to months after the injury. So weeks to months. I've been trying to hit on that and hammer that. Antibodies are usually detected within weeks after presentation. So they present within weeks to months. Sometimes when they present, they'll have antibodies. Sometimes they won't, but within a week or so, you'll be able to measure antibodies in the titers. Okay, it occurs after antigen is released. So here's your here's your heart, and Before the heart gets injured, nothing. But after the heart gets injured, something. So it's always precipitated by an exposure of the heart to immune elements. It's always precipitated after exposure of the heart to inflammatory elements. There can be recurrence. It's not, you don't always going to get recurrence, but there can be recurrence, and there's usually prolonged latent periods, and this is not typical of other types of diseases, especially in a normal clinical setting. And the response to NSAIDs and colchicine is really good, and it's slightly more common in women, which you see with a lot of autoimmune diseases. So what's the other etiologic hypothesis? Is viral, and the reason people think it's viral is because it's seasonal, or there's a seasonal change in its occurrence, and it occurs even in immunosuppressed children. So I actually read the study that talked about this, and in these immunosuppressed children, they were given some good immunosuppressants, some cyclosporin and a bunch of other immunosuppressants, but one thing the study did not mention is they didn't measure the antibody titers. So I mean, if there was an antibody response, they didn't check. But the fact that it occurred in immunocompromised children may indicate that there are multiple etiologies, that it could be viral and it could be autoimmune, or it could be many other things, so it could be a mosaic. And lastly, there's high viral titers, so in a lot of cases, not in every case, but a lot of cases have high viral titers, and there's a statistical significance, to that finding. Now, I just put this on here because I thought it was really interesting. I read it in a lot of people's study guides, and I read it in a lot of the papers I've looked through, and that is that it's never occurred in a child under the age of 2. Maybe that corresponds with the immunologic development or something along that nature. I'm not sure. So I have a proposed mechanism is because another paper I found on myocarditis that a very extensive study. One group did different experiments over the period of like 10 years, and they showed that thymic epithelial cells do not express alpha-myosin. And so they pointed out the numerous number of involvements of the heart with autoimmune disease. So autoimmune diseases tend to impact the heart, and it doesn't matter, almost any of them that you talk about, you can find associations where they have impact on the heart, usually a myocarditis or pericarditis or something along that nature. And they showed that we do not have a mechanism of central tolerance to stop T cells, so this is T cells we're talking about, to stop the T cells from being able to recognize alpha-myosin. And it was a really, really, really good article. I recommend it. Look up PMC 3472-104 on the NCBI. And essentially what they showed is that whenever they take rats and they cause rats to express alpha-myosin in their thymus, in their thymic epithelial cells, then those rats quit. They don't get these myocardial autoimmune disorders. Whenever any type of autoimmune disorder, they don't get it. It doesn't impact the heart. Whenever they cause these rats to express alpha-myosin in their thymic epithelial cells, but neither rats nor humans express alpha-myosin in our thymic epithelial cells. And an interesting tie-in is that we have reduced thymic, so people that have reduced thymic expression of the alpha subunit of the ACH receptor have an increase in myasthenia gravis. So maybe the thymic epithelial cells don't express alpha-myosin because typically alpha-myosin isn't in a high enough concentration in the serum for an immune response to be mounted. And when there's an injury, either by virus or by any other mechanism that causes that increase in dendritic cells, so we've got dendritic cells that are going to go to the lymph nodes and present stuff to the CD4 cells and to B cells. These CD4 cells are just standing by waiting, and whether or not there are B cells there that can react to it, nobody knows, but if there are, then they need that co-stimulation from CD4. And when they get that co-stimulation, then bam, autoimmune, post-cardiac injury syndrome. And so what I'm saying is I don't know in the case of post-cardiac injury syndrome if it's alpha myosin or what it is, but I think that the mechanism is probably very similar. Okay, so I think I may have already said this, I don't remember, but you get a pleural effusion with post-cardiac injury syndrome, and they find the anti-myocardial antibodies in that effusion. So these antibodies against the heart's myocardium, probably the alpha myosin, I don't know, but they find these antibodies in the pleural effusion, and so the link between the pericardial and pleural involvement, I looked for this everywhere, and then I finally found an article that says, hey, nobody knows. But what they do know is that whenever you have an injury to the pleura, it can also, in very rare cases, cause post-cardiac injury syndrome. So maybe there's some cross-reactivity, some antigen in the pleura or in the lungs is very similar to the antigen that's presented in the heart. I don't know. I think if somebody did some genetic analysis with that kind of thought in mind, something might be found. I don't know. Okay, so what's the treatment? NSAIDs and colchicine, that's the standard. So just the use of NSAIDs alone can reduce recurrence. So if you give NSAIDs within the first week of the onset, then it can reduce the number of recurrences that happen. If you give them after that first week, then it can reduce the symptoms, and it can get things to resolve faster, but it won't reduce the recurrence. And then if you use colchicine with NSAIDs, it further reduces recurrence. And not only that, but if you do colchicine prophylactically, I almost forgot to put this, but if you use colchicine prophylactically, then it can actually reduce the number of people that get post-cardiac injury syndrome. So you have I guess the take home, I don't know how much colchicine costs or whatever, but if you have a person that came in after a car accident or something, you might consider giving a prescription of colchicine just to make sure, for up to a month or so, just to make sure they don't get a post-cardiac injury.